All right, welcome everybody to another episode of the Interventional Endoscopist podcast interview series, and I'm your host, Munkubal Suchdev. Today, I have the distinct pleasure of interviewing a friend of mine, Dr. Sunil Amin, who is currently the system-wide director of interventional endoscopy at the University of Miami, and he is also the program director for the Advanced Endoscopy Fellowship and the director of Advanced Endoscopy. So, Sunil, welcome, and thank you for joining me.
Thanks so much for having me. It's looking forward to it.
Yeah. So Sunil and I first met just by chance. Actually, I've been following him on Twitter for over a year. And so he and I have been commenting on some of the same things. And then I think it was August of 23, we had the opportunity to meet at a fellows course in Chicago with Boston Scientific. And we struck off, we had a good conversation and we were talking about the podcast. And, I realized that he's been pretty instrumental in developing the practice of GPOM, especially in his region, but also nationally. And I thought it'd be kind of a nice topic to talk about because it is a growing field. So before we get into that, though, just a little bit about his background. Sunil was a medical resident and GI fellow at Mount Sinai, and he was an advanced fellow at Columbia at New York. Sunil, welcome again, and let's start off by talking a little bit about your background.
Sure. So I grew up in Canada, Vancouver, and then went to college at Columbia, stayed in New York forever. Like you said, went to residency and fellowship and medical school at Columbia as well, residency fellowship at Mount Sinai, advanced at Columbia, and then just kind of hung around. After that, I ended up in Seattle at Virginia Mason for a couple of years, and in 2019 moved to Miami. Couldn't be happier. Things are going well.
Yeah. Are your parents still in Vancouver?
They are. My parents are still in Vancouver. They're both retired physicians. My father's a family practice doc. My mother's a child psychiatrist.
Yeah. Must have been nice to be in Vancouver at that time when you can just go back and forth over the border, but now you're in warmer weather with less rain and more sunshine, I guess. So.
Trade off.
Yeah. So so what kind of prompted your decision? I mean, if you talk about your early years, Neil was my last person I interviewed, and we joked around about, becoming physicians because that's kind of the Indian thing. You're told in the womb that you're going to be a doctor, especially when both your parents are physicians. But how did you end up going through the medical system? How do you decide to do gastroenterology, medicine, that sort of thing? What brought you down that pathway?
Yeah, no, I wish I could say something special, but it's exactly what you mentioned. In Chicken with both my parents as doctors, and from an early age, I had a little white coat, walked around, followed my dad around, and and they just ingrained it into my head that that's what's going to happen. And so, I tried to sway a little bit in college. I majored in economics. I thought I was going to kind of go to Wall Street, maybe leave that door open, but then I applied to medical school, got in, and I was overjoyed and happy at this point. I think one of my friends in med school put it best when I was having second thoughts. He said, "Could you really imagine yourself doing anything else?" As frustrating it is, when we do this, I really couldn't.
Yeah.
That kind of put it at ease for me. In terms of GI, I think like a lot of us wanted to do something procedural, but also wanted to have that cognitive aspect of it. And for me, it was kind of between ENT and GI. And ENT, I kind of did a sub-I in it, and it was just these tiny little fields and things like that. It's microsurgery, and GI just felt so much easier to understand. With the plumbing, right? So.
Yeah, and I think it's actually interesting because in the last interview, if I recall correctly, Neil was saying that he was also interested in ENT versus GI, and
so funny.
Yeah, so it makes sense because I do think a lot of us who have that inkling to go into the medicine/GI world, we do like the ability to talk to patients. Not that the surgeons don't, but we tend to be more 50-50, I think, clinical and procedural versus some fields where it's a broken knee, have hammer.
Yes, exactly.
I guess. Okay, and so how about some of the mentors that maybe influenced your decision to go GI and specifically therapeutic endoscopy?
Yeah, so when I started doing GI, obviously, one of my attendings told me not to get seduced by the scope. I remember that. IBD attending, but of course I did, and I knew. I think I knew early on, that I wanted to do interventional, and so I kind of did my research around that. But some of my early mentors were Dr. Michelle Kim, who was really instrumental. She's now a chief at Cleveland Clinic. A gentleman named Harold Frucht, who is kind of a kind of GI syndrome type person at Columbia. These are people that kind of took me under the wing early and kind of got me into GI research. But then once I started doing procedures, really, one of my biggest mentors was Chris DeMayo at Mount Sinai, and kind of he really encouraged me in terms of going into advanced endoscopy. And I matched at Columbia, which was, really where I wanted to be. Amrita Sethi obviously is just a visionary advanced endoscopist, incredibly talented, really most impressive person I've ever really seen scope. And so I wanted to learn from her, and luckily I was able to spend a year with her. And so, to this day, I think a lot of us who did their interventional fellowships, those mentors are kind of the ones that stick with you, as we move through our practice. So she's kind of the person I rely on most today.
Yeah.
Same with, actually, I was fortunate enough, I think we'll talk about this later, but I was able to go to Prague to do my third space training with a gentleman named Jan Martinek. And he really is kind of my second endoscopic mentor. So I have a little bit of a cool situation.
Yeah. Yeah, I mean, the mentor thing is amazing because even, I finished my advanced year in 2010, and I still hear in my ears sometimes during a challenging ERCP, John Martin's voice, or during an EUS or another ERCP, maybe Sri Kamanduri or Raj Kaswani's voices. It's kind of freaky because, you're like, it's been 14 years since I've been in the same procedure room as these guys, but their voices still kind of echo in your head when you're doing things. And it means mentors are super important in this field. And then, the only thing about Dr. DeMayo, which I love, one thing that he did was when I became the program director of an interventional fellowship, we had these program director meetings through ASGE, and he was pretty active in them. And he was the only guy of a group of about 40 or 50 interventional program directors that actually had a typed out and written syllabus for his fellows. Like, this is what we're going to teach in the first month. This is what we're going to teach in the second quarter. And I actually, when we started our program, I emailed him. He shared that with me, and it really helped us kind of plan our fellowship properly. So, I mean, he was super organized with that stuff. So hopefully he's still doing it, but he was doing a great job.
Yeah, I know. He was always a great teacher.
Yeah. All right. So let's talk about that. I mean, you brought up the topic of GPOM, and that's kind of something that we're going to speak about. Let's start off with your journey of how you developed the program, and we can go back to your training that you were talking about with Dr. Martin over there. And so let's
yeah. So, I guess, not just GPOM, but POM as well, and really all just kind of third space stuff, ESD, POM, GPOM. And I think it's interesting because I talk to a lot of people that graduate advanced fellowship today, and I, right after advanced fellowship, all I wanted to do was EUS, ERCP. I wanted to get really good at that. All I wanted to do was cannulate native papillus by myself and needle knife by myself without anyone around, and just kind of learn those skills that I didn't feel like I fully got during advanced fellowship, because you always had someone take the scope for you and it was time to needle knife, right? Unless you got that big bulging stone there, then they let you, but that was it. And, I watched a lot of third space cases. Amrita was really building her POM practice, but I didn't have that much hands-on at that time. That was kind of her time with the scope. And so, right away, that was my itch to do that, to really get good at ERCP in the US. And, I didn't really have an opportunity to explore third space at Virginia Mason because someone was already doing that. I did a lot of time at a community hospital where we were trying to build up the advanced stuff there. So that kind of satisfied my itch. And then as I got to Miami, there was a big void. There was really no one in the city doing third space stuff. And I think that's how a lot of it starts. And it's a huge city, and there was a huge opportunity there for me. But the question then was, how do I start?
Right.
How do I do this safely, responsibly? And not only that, how do I get the patients? So I reached out to my mentor. That's the first thing I did, and said, this is what I want to do. And I knew she'd support me because, I'd done these cases with her at Columbia, and I know she kind of wanted me to follow in her footsteps to some degree. And what we decided to do was have me apply for the ASG Endoscopic Training Award, which is they give it to 3 people every year. I think my year they give you something like $5,000 or $10,000 to basically go somewhere international and learn whatever you want to learn, whether it be third space, whether it be anything advanced endoscopy. So I wrote this proposal, and you have to apply with a mentor. Mm-hmm. And, she obviously has contacts, all throughout the world. She does lots of these lab courses. And she said, who I think would be great is, Jan Martinek in the Czech Republic. And, it's maybe somewhere that you can get hands-on experience.
Mm-hmm.
And, there was some discussion about maybe going to England or, Japan and these types of things, but you don't really get hands-on experience there. And so that was really what clinched it for me. And he was just the nicest man. He was so welcoming to me. We wrote up this grant together. I submitted it, and I was lucky enough to get the award.
That's amazing.
Yeah, and I was new enough in Miami that it was within. It was right during COVID, I think. I got the award in February. COVID happened in March of 2020.
Okay.
And then we were kind of trying to figure out what month I could go. And so we kept pushing it back. And it ended up going in October, November, when there was like a window of time when there was like, it was kind of safe to travel. And as soon as I got there, Prague went on lockdown. And I was like kind of pretty much confined to like my little Airbnb and going to the hospital and just kind of finding the one Indian restaurant around the corner and just taking takeout home every night. But in any case, so that was how it happened. But the experience was really kind of second to none. What we did was Dr. Martinek has a tracker. He's published on Third Space and Teaching Poem, and they're the highest volume center in Prague because there's not a lot of people that do poem, as you can imagine, in Prague and especially in the Czech Republic. So everyone from around the country gets referred there. They've done, I think almost over 1,000 poems at this point. They do well over 100 every year. They've been doing it for 7 or 8 years. And so, he was really at the point in his career where he's ready to teach and train, and he doesn't need to do it for himself anymore. And so it worked out really well because the way he approached it was, we do a lot of pig labs. We do a lot of training on pig labs. When we're ready, we move on to live, human cases. And so what we did was, as soon as I got there, we basically did 10 poems on live pigs, and with each pig, you can do 4 tunnels. You can do anterior, posterior, kind of lateral. You could do up there. The pig esophagus is very, very long. And so you could do a couple tunnels. And then that was what we did to kind of get the initial skill. And then eventually, he would do maybe 2 or 3 a week. And so I was there for 4 weeks.
Mm-hmm.
And, I just shut down my practice in Miami and I went there, and my chief was supportive, let me do that. And I just took a bunch of vacation early on. My wife was like 30 weeks pregnant at the time. So this was my one opportunity to go before I was like locked down. I was my second kid. So we took a gamble. It worked out.
Oh, wow.
But it was good. So I did all these poems on pigs. And then I started watching him, and we would do it methodically. So I would just learn to close. And this is how I teach my fellows now. We would just close the mucosotomy of clips out for the first case. And then I would do a little bit of the dissection. And then I would do a little bit of the myotomy. And then, by the end, I did a poem start to finish, safely with his supervision. And that was really just that. And that was what we were hoping would be the outcome by the end of the month, And so that worked out really well. And then I got back to Miami and I was like, okay, I'm ready to go. Luckily, we have a pig lab in Miami. And so I was able to keep doing what he taught me. Every month I would go to the pig lab and do all these tunnels, do all these poems. And then I mostly focused on poem, not really G poem at this point.
Right.
Because that was just kind of what the need was. That was what I was trying to learn. And G poem was still a little, 4 years ago, 3 years ago, still a little, it hadn't really caught on as much. So I did that. And then I was like, okay, I'm ready to go. But now I need the patience. And I came back in November. I didn't do my first poem until April. And I was able to line up 3 on the same day. And Amrita came down and proctored me for these.
Gotcha.
And that was what we decided with the university is the safest way to do it. And what me and Amrita thought was the safest way to do it as well. And so we did those 3 cases in a day. That's all we scheduled for the day. Took my time, and they were really hard type 3 cases. But that's what you get when you're starting a program. People just kind of like, they don't give you the easy things. They send you the hardest cases. We have patients who have a sigmoid esophagus, who have achalasia for 20 or 30 years, and it's like 85 years old, and it's like, okay, here you go. Can you do it or not? And that was one of the things that I really learned about building a program, is that you just have to step out of your comfort zone. You're not going to get the perfect, 35-year-old person with achalasia for 2 months with a perfectly straight tubular esophagus,
Right.
It's not going to be like that. You have to step out of your comfort zone and do these cases. And so,
And you got to be adaptable too, right? I think the
Yep.
thing is that um, a lot of I've had people who refer patients, and they kind of put this front up that they want everything done perfectly and they don't want their patient harm. But reality is, most guys, when they can't do something, they just want someone to take care of it, and
Yep.
they want you to try. Even if you get down there and aren't successful, or you realize it's not possible, at least you made the attempt, and that goes a long way in building the practice, because they know that this is someone that I can send someone who's willing to listen and willing to look into it and willing to try. And that's, I think, goes a long way as well, even if you're not successful in building the first case or second case. But I think it's important to be saying yes to taking it on and understanding that you have to take a bunch of the hard stuff to get the easy stuff. So
Yes, exactly. No, and then, so after that, those worked out fine. I really started to hustle. The word got out that I was doing them in Miami. They didn't have to refer to Orlando or Gainesville anymore. The outcomes were good.
Right.
And then things just kind of, spiraled in a good way. But it was so important, to really just keep in touch with the referring providers, going out of my way to text them, to let them know everything that's going on. And then eventually it became easier. And I got those cases, those easy cases, etc.
Yeah.
And now, we've done over 100 ESD, POEM and GPOEM combined cases. So, things are going well. And I think we have a good system at this point.
That's awesome. So what year or what was your first case? Was that January 21 or was it?
That was April 21 was my first one.
And you spent 4 weeks in the
in Prague in October, November 20. So it took me a good 5 months before I got the case, and that was practicing. That was a little bit of a, kind of like a low period, because I had all this training, I wanted to do it, but I was nervous to do it. But I also, that's the reality. It's like, you got to get the cases. No one's done it here before.
Right.
You gotta find the way to do it.
No, that's amazing. But I think the most important part of your procedure, of your success in building the program, was actually the fact that your wife was willing to let you go when she was 30 weeks pregnant. So I think I did a podcast at the very beginning when I started this about, applying to interventional fellowship. And in that, I made a point that a lot of people, your program is only a year long. So a lot of times if your spouse is working, they may not go with you, your significant other. They may say, we'll just do the long distance thing for a year. And so it's really important. And I say it kind of jokingly, but it's true, is you do need that family support in addition to your chief and your university and your practice. You need family to be able to say, hey, this is okay, because that's actually pretty admirable. So how tough.
Very lucky. Yeah.
Is she a physician as well?
She's a urologist, so
okay.
She gets it,
So you guys have the perineum covered, it looks like.
You got it all covered.
So what do you recommend to your fellows now who have an interest? Obviously you're able to mentor them to a degree. But are you telling them that now that you've been almost fully 2 years into this, are you feeling like they're getting enough experience with you to be able to practice third space / POEM independently, or do you still encourage them to seek additional training opportunities after fourth year?
Yeah, so it's almost 3 years now. But I'm just, but you're right. So I think that my fellow this year is going to be able to do POEM independently, because we're really working towards that, because that's what her job wants. And my fellow last year, it wasn't his priority to do it, so we didn't push it as much. So during the cases, I really tried to get her to do more and kind of and we're doing more pig labs and things like that. So, but with the caveat that I think that I would like to be there for her first few cases to proctor her doing them in the hospital and kind of do it the same way I did. I think so much of this procedure, and so POEM and GPOEM as well, so much of the value in it is you can get by watching. And so the cognitive part of it is so important. And so I like to do it, and we talk through, where's the posterior, where's the anterior side, basic stuff to start, and then eventually we get, do you think that myotomy is good enough? Is that full thickness? Are we through the GE junction? How do we tell we're at the GE junction? What are we going to do in this situation? And those kind of cognitive aspects of it are really important, because if you have the technical skill, but you don't know how far to cut, you don't know how to deal with the consequences. We have a mucosotomy, how we're going to deal with that. If we go too far down, what is that structure we're looking at? That's the diaphragm, things like that. You don't, and then the experience of maybe having complications, seeing what happens to the patient afterwards. These are all things that you can do when you do an advanced gear and you do, 40 or 50 you're exposed to 40 or 50 palms. So that was, I think that's a really important part of it.
No, absolutely. And I think, I specifically for these type of third space procedures and, anything that we do that's beyond or anything that's interventional, I think it can't be overstated how much spending time learning these procedures and actually seeing the post and pre-care is helpful. I mean, I have a lot of people who do EUS that, maybe went somewhere and watched someone for a month and they start doing it. And, that has always been a problem for me is that, you don't get to manage those patients afterwards, but I can't even imagine doing that in something as advanced as a third space endoscopy or something even more than that. So
Yeah.
I think it's really important. But do you see the future of interventional? And I ask everybody who I've interviewed this question when third space or endoscopic oncology or any of these things come up. Do you see this being a part of interventional endoscopy fellowship moving forward, or do you see this being kind of like a subspecialty interventional fellowship? Like, what do you see the future of training looking like in 5 years from now when all these new procedures like bariatrics and oncology and third space come out, So,
Yeah, kind of before my thought was that you really need to have an extra fellowship to learn this sort of stuff because, you can't teach it all in 1 year. You can't teach ERCP, EUS, Palm, EST. But now there's so many people that are there's all these different opportunities to get training, all these different pathways. And
right.
a lot of young guys and women are doing palms and trying to learn palm and G palm and ESD and they're hungry and they want to do it. And so I think there's so many people doing it that it's really getting diluted. And
Yeah,
it's hard, honestly, to do good quality palm, just like ERCP, when you don't do that many, when you do like 5 a year,
no,
And so
absolutely.
I think it's going to get, it might get reconsolidated, but I don't think that everyone is going to be able to do it unless you're at a kind of a high volume referral center.
Yeah, and I actually agree with you completely on that because, like, I just talk about the Phoenix experience here. We have Mayo Clinic up north where we have Norio there, and we have a physician named Christopher Patea or Theodore Patea. He learned poem probably. He was one of Stavros's fellows, and I think he learned poem 5 or 6, 7 years ago, something like that. He did his first one. And now he's done about 200 in the last few years and, or close to that. I don't quote me on the numbers, but the point is that, Phoenix is the 5th or 6th largest metro in the US. And we do have a couple of new guys who moved into town that are doing poem, a couple of people who are interviewing for jobs that want to do it. But there's just, and I know there's more indications than achalasia, but there's just so many achalasia people in the world. And is it really smart? And I think about myself, like, do I want to learn poem now in my career? And yes, it's a cool procedure, but if my mom and dad needed it, or if my brother needed it or something, would I do it myself or would I send that to Norio or Chris? And the answer to me is pretty obvious what I would do. And so if I don't feel comfortable doing it on my family member, what am I doing? Just kind of dabbling in it when it might take me 3 to 4 hours when I've got a guy who can probably do it in 30 to 45 minutes or even, right around that time frame. So I think the point is well taken. Not everyone's going to do it. And so that reason, I think we probably are going to end up in a situation where maybe interventional, if you get enough EUS and ERCP in a program, you do it for 6 months. And then the next 6 months you spend focusing on that subspecialty. I mean, what is it third space? Is it advanced tissue resection? Is it endohepatology or endobariatrics? And I think that's kind of what I envision happening, but more to be seen, I guess. It's exciting time. So
yeah, no, we'll see how it plays out. Hopefully everyone that does it will go through the process, will really feel comfortable doing, get adequate training. But all the data we have about palm, 95 to 100% success rate, it's all predicated on high volume center of people that are doing this a lot.
Right.
And a lot of times even I'm second guessing myself, is my myotomy far enough? Is that really the GE junction? After having, done this many of them. And so I can only imagine if you've only doing your first 5, versus someone who's done several hundred, how much more confident you are. And so we'll see if the outcomes end up being worse in the community than not. I don't know. Maybe they won't, maybe they will, but we'll see how it plays out.
Yeah, absolutely. And also just another kind of maybe putting on the crystal ball. Do you see, like, in the future, the practice of EPOM or GPOM being more of your kind of bread and butter as this program advances, or as more people start doing these procedures?
Yeah, that's a good. Actually, my first year doing it, I did a lot more GPOM than EPOM because EPOM was so, achalasia, like you said, there's only so much of it to go around, and these patients, we had to find them. with GPOM, everyone, our clinic is full of gastroparesis, and so it's so easy to find these patients that we, met our criteria, which was medically refractory gastroparesis, that didn't have pain predominant symptoms and they didn't have evidence of real pancreatic motility. And, as we started doing GPOM, we realized that, it's almost, the outcomes really aren't as great, as EPOM. There's about 70% or so is a success rate. And no matter what we study, we can't figure out whether it's diabetic or post-surgical or idiopathic that does best. But, I think we do know, based on the sham control trial in gut that I was part of, that Dr. Martinek actually did, that it does work, in the right patient.
Right.
Clearly it works, but you just have to get the right patient. So I think that GPOM, I don't think it's going anywhere. It definitely works. And the way I kind of look at it now is, if you have medically refractory gastroparesis, you can't take Reglan, and maybe ideally you have objective evidence of pyloric dysfunction by an endoflip or something like that. Give it a try. I think a lot of us are liberalizing our criteria a little bit because it's safe. It really is safe.
Yeah.
As someone who's done I've done ones with someone who's had like 40 Botox injections before. I've had mucosotomies up top. I've had full thickness, myotomies, and it's always, they end up really fine. It's really kind of a generous area. It's kind of forgiving. So I think the worst case, it just doesn't work.
Right. It seems like a safer location, for
right.
that kind of intervention as well. So, especially how thick that area is.
Yeah.
Yeah. And so, okay, so it's all fascinating. So talk a little bit more, if you don't mind, not just about the GPOM, but just now that you're the system director as well, kind of how are you going about, number one, how do you go from, being an advanced attending in Seattle to taking over for the system?
Yeah.
That kind of, briefly that pathway, and how are you growing your program now? Where are you guys today as a unit and as a department?
Yeah, well, that's a great question. I think, it's all about opportunity, I think, and being in the right place at the right time. And so when I was in Seattle, I was fortunate to be around some really fantastic advanced endoscopists, Shannon Arati, Andy Ross, Joanna Lott, Dick Kazarek. These people were all really great, and they are mentors to me. But I was kind of I was the new guy, and I was in the community hospital a lot. And, I wasn't the one that was being referred patients to. I was kind of like 6th or 7th in line for the ERCP. And so there's no way I was going to get to be doing third space stuff there. And then, my wife was doing her fellowship there as well in urogynecology, and then she finished. And my hope was that I would kind of become more ingrained in the core group at Virginia Mason, but we also needed to go somewhere where they could hire both of us. And it didn't seem like there was an opportunity for her to stay. And so we kind of did the search, ended up in Miami. And we'd never really visited before, except that my wife had been here for a bachelorette, and that was it, and we just kind of took the plunge, and we loved it. But I was lucky enough to get to this. This program was not as developed as Virginia Mason. It was not as developed as Columbia or Mount Sinai or anywhere I had been. It was kind of practicing advanced endoscopy, kind of like a private practice type model, as opposed to an academic model. They weren't publishing a lot. They didn't have a national reputation. And I saw it as a real opportunity, but we did have a big cancer center. We did do a lot of complicated stuff, but no one knew that we were doing this stuff. Within Miami, University of Miami is really the only academic shop in town. There's other health systems, but none of them have fellows or residents, and they're not really kind of on the academic track and publishing. So I basically got here, and I was kind of, the third person here. And then the other two kind of left. They looked for other opportunities. There are certain things that frustrated them here about Miami. And all of a sudden, I was the most senior person. And I had this drive to really grow the program. And I was doing all the third space stuff. I was tweeting a lot. I was growing our national reputation. I was trying to publish. Right. And I got some, attention from people. And I started making friends with people in the interventional community. People knew who I was. And that, in turn, shed light on Miami that people really didn't even know we had a program before. And that allowed me to recruit some people. And then at that point, I think our chief had enough confidence in me to first make me director of advanced endoscopy, and then eventually assume the role of system-wide director. And, I will say that in order to kind of make those leaps for yourself, you really need to advocate for yourself as well. And if you think you're ready for something, you need to ask for it. And no one's just going to hand you things unless you advocate and ask for yourself. So I said that I wanted to do this. These are my plans. And they said, well, I think that sounds great. And that you'd be a great leader for us in this respect. And that gave me, having these positions gave me the clout to recruit people a little more seriously and reach out to people and arrange, dinners in the evenings for Miami-wide advanced endoscopy people to show them what we were doing.
Right.
And that's kind of ways that I'm focused on the outward growth of the program. I think we're kind of maxed out with your internal referrals, but we have a lot to grow in terms of outside referrals. And so besides the third space stuff people send to us, but the US ERCP volume, really trying to build that up.
Yeah.
Go ahead.
No, sorry. That's just going to say that's just the bread and butter for an advanced program is to have that volume, and the rest is great stuff, fun stuff. But it's like we say in GI, colonoscopy pays the bills for the most part. EUS will pay the bills for an advanced endoscopy program, for the most part.
Yeah, exactly. No, we do high volume stuff, but we're all my ERCPs are Hyler strictures, whereas I never get the stone cases, and we don't have a system where those come into University of Miami. They all get taken care of by the community. But like to grow that and let people know we do that stuff too. And I have to give credit to my partners, Dr. Bala, Dr. Kumar, Dr. Parkin. We really have just such a fantastic dynamic between us that I've always hoped that we would have. We all go into each other's rooms. What do you got today? We all share the call. We're all there for each other. What do you think of this? And that's made us all better.
Yeah. No, the rising tide raises all boats, I guess is what they say. But yeah, no, that's amazing. And I from my experience as well, I think having colleagues and partners that you get along with well, that are willing to, share the burden of call and whatnot with you, it makes it a much more collegial, fun environment. Then you grow that program together. So that's amazing. Yeah. And you guys are four people in the interventional department right now at the university?
We're five. We hired one of our former fellows. So we have a health system. We have University of Miami and Jackson. So between the two hospitals, there's five of us, and we're looking to hire another. So.
Very cool. So if anyone listening is looking for a job, you know where to apply. If you like warm weather. So
yeah, exactly.
Okay. Well, hey, Sunil, it's been great talking to you. I really appreciate your time. I know it's late over there, so thanks for cutting out, some time for me. Just want to thank you. And also, one thing that we say at the end of this podcast for everybody, join your societies, ASGE, fight, whatever it is that you're passionate about, because that's going to help grow your practice as well as the GI community. And I also end off with the PSA about mental health. If there's anybody out there struggling, reach out to your local 800 number or other physicians and just get some help before, things get too stressful for you. But once again, thank you so much for your time. I really appreciate it. And I look forward to, one more thing I was going to ask you. Are you teaching at any courses or anything coming up in the near future? Anything that you want to, put out there for the community to know about?
No, well, we're in the process of planning our first kind of Miami advanced endoscopy course. So,
very cool. When do you envision that happening?
It'll probably be in the winter. Like it's a nice time for people to come to Miami. It may not be this year, maybe a year from now, but I think that's keep an eye out for that.
Yeah, no, then those are hard to plan. I mean, I have a few friends that have planned some courses, and it's not easy, man.
Yeah. I guess it is the winter now, but I don't even think about it because it's beautiful and 80 degrees in Miami. But
Vancouver right now.
Phoenix, yeah. But no, thank you so much for having me. It was a real absolute pleasure. I love talking about advanced endoscopy, and we love to talking to you, and we can talk for hours, I'm sure. But,
oh yeah. That's one of the reasons to do this podcast is not only. It's to get to meet people, and I like talking about the stuff as well. And honestly, I'm a chatterbox. I could go on for days and talk about stuff, but we all have stuff to do. So, but yeah, I hope thank you again, and all right. So, and thank you, everybody. That's our episode of Interventional Endoscopist podcast, and stay tuned for the next one in the next few weeks.